oh, we don't know when we can start, we don't know when we're going to do it. You've given yourself that 6 months.
Yeah.
And also you're looking to increase the coding, you said?
No, what we're looking at to marry it up between obviously community and GP surgeries.
So when you say marry up, is that to see if you're operating the same procedures, or you're cross-referencing what each other has got?
Yeah, what we're looking at is cross-referencing at the moment. As part of that, we could be looking at increasing coding.
So you're looking at their database and see who's on the GP's database as having a diagnosis of dementia, and then you're looking at who you've got in memory assessment service and see if they marry up. So would you say then that overall is to achieve the aim of increasing the diagnostic rate?
Yes.
And you're going to be doing it by cross-referencing, and that's your cycle of change?
Yeah. Okay.
To plan through. Yeah. So again, coming back to Mark's example, how much would you expect to increase the diagnostic rates by doing that? I don't know if anybody else has got anybody to jump in to look at that, because that's almost like your answer, isn't it? Your answer is to cross-reference where you want your aim. What are you trying to achieve?
Yeah. Because I know a lot of people with diagnosis of dementia, for whatever reason, sometimes they missed on that dementia register. So I think it's really important that we have a smooth transition really from community to primary services to GP surgeries.
So your aim is to increase the number of people with a diagnosis of dementia by a certain percent, by an amount. You want to give yourself that sort of percentage, and then you're going to do that over a 6-month period. And you're going, the way you're going to do that is to work together with primary care to cross-reference those databases. And Rebecca, I know, wants to come in. There's a nifty little tool that they've been using with one of the GPs that could be another test of change or something like that, and looking at the GP lists where they were data cleansing. So there's lots of ways that you can do that with lots of different tests of change, really.
So I think that would be a really good first cycle, isn't it? Would be that cross-referencing. That's your first PGSA cycle, and then building on there. But that's exactly what I was going to say, Michaela. Lovely. Exciting.
Hopefully, I hope I'm not too ambitious though.
I think that's a good one and a really achievable one that will make a massive impact.
Yeah. And is that with one GP practice?
No, she's the cluster lead. So at the minute, I've limited my research to 6 months in the Caerphilly Miles services, because I wanted a small sample really, because I think if once it gets bigger, it gets a little bit confusing. So in all fairness, Sue's not here, so I need to go back to Sue. So I think Sue looked at the lists when we last met. She looked at who was diagnosed. So I think this will give us good guiding now, and I can reiterate it back to Sue.
What we find, picking up on Michaela's question there, is it one GP practice? Because you've probably got 5 or 6 GPs connected to yourself as a memory assessment service. I thought there might be.
I think she was based in one surgery, but obviously she's the cluster lead for the whole clinic.
Okay, so because what you'll find is the different GPs will have different difficulties, so you might need to do different change cycles. So to make that even smaller, I would probably just do one GP connecting to you, and then you can learn from that, and then there might be things that you can scale up to the other GP practices as well. But they'll all have different constraints and difficulties within their systems and processes. Thanks, Anne-Marie.
You'll also, I think you'll also find you will find, if you can get down to the detail, that each GP practice will have a different rate of dementia diagnosis. So by getting that intelligence, you'll be able to perhaps focus maybe on the worst rate. So you could go there first, and then see what's going on. And I know Rebecca's doing a lot of this work with Adam Watkins, our analyst, as well. So all of you have got an opportunity, if you're looking at this kind of data, to sort of link in with that work. That helps that for your whole region.
Yeah, I might be able to get you some baseline data there.
Oh, that'd be lovely. Thank you, Rebecca. And thanks for your input, everybody.
No, that's great. No, it's good to work together, isn't it? And that's what I hope we can do from this session as well, is just help each other for, you know, building our aims up, etc. So again, it's not a test at any point. If anybody's got anything to add or needs some help in certain areas, then please ask. Is anyone happy to go next? Could I pick on possibly Judith? Would you be happy to go through your aim next? You're next on my screen. If that would be okay.
It's fine. I was trying to find the hand button anyway. It's fine.
Okay, no problem. Thank you.
Okay, so as I was saying before, what the sort of work that we've been, or work I've been doing in our service, in the memory service, is really looking around the interventions and how we can improve uptake there. So I try to sort of frame it within that model for improvement that you were talking about. So what we're trying to accomplish, improved targeted intervention offers and improve the uptake of those, and how do we know there's a change? So it would be service user feedback and percentage uptake again, wouldn't it? And then also the success rate, so people engaging with it from the start to the finish, and then what change can we make? So again, it's what interventions are being offered, and then the pathway around that. So what I was thinking was, would the aim be something along the lines of to improve the uptake of intervention offers in the memory clinic by a set percentage over the next, say, 6 or 12 months, just to get a baseline measure of, if we're making this change, is this then improving uptake? And then we can sort of cycle further and further along with it and continue to improve it. Is that right? I don't know.
I think you're getting down towards the bottom of the funnel, to be fair. So yeah, I think it's good that so far, from what I've heard, just my own reflection, I think you structured that quite well, and you got some good specifics in there as well.
Okay.
It's just understanding, again, a realist, as we said from the SMART aim, a realistic kind of aim with a percentage, not to be unfair to yourself.
Yeah,
the other thing there as well is your testing, you know, because having that list of interventions, post-diagnostic interventions, there's a range of them, isn't there? So overall, you want to increase the uptake of those interventions, but your tests of change could actually look at different interventions.
Yeah,
so
no,
we completely changed.
Yeah, we completely changed the intervention offer. So what I wanted to do was initially look at trying to introduce a more targeted intervention pathway rather than just going, you know, CST yes or no or something. You know, where are you within your dementia journey? What's the most appropriate targeted intervention? And then look at the uptake of that. And then try and look at more of them individually as to what's working within each one.
Yes, there's your nice cycles. I'm doing a similar one with my early intervention in psychosis, because national standards give us, I think there are 7 targeted interventions. And so what we've done is actually say, how are you achieving on all 7 being offered, you know, that kind of thing.
Yeah, that's what I've been looking at. So obviously looking at the NICE guidelines, but looking at it from the MSNAP perspective as well. So what do they recommend, and then what is best practice? And then from that, I have then taken what I think is the most appropriate targeted intervention offers. So I've got basically three separate ones that cover the recommendations, and they kind of cover different people, you know, different parts of the dementia journey. So looking at initially life story work reminiscence, and then CST, and then home-based memory rehab, and then that gives you a bit of a pathway depending on how well people are able to engage, and then looking at it from a group and individual perspective as well. And that's what we've been sort of working on over the last 2 years here.
So you've got a number of nice little tests of change there to look at the different elements. Yeah, any other questions there, Rebecca?
Sorry, I can't hear you.
I'm really interested in the order of that. That's really interesting. I'm just wondering if cognitive rehabilitation actually comes first for those people who are very early, then cognitive stimulation. I'm just wondering the order of that, but that's brilliant.
I'm looking at it the other way around. So the cog rehab sits within the memory rehab program,
right?
And that's sort of for the higher functioning people.
That's right. That's exactly
And then
so I thought you said it the other way around, Judith. Sorry.
Oh no.
No, it wouldn't work. Like, oh, you're going to get that lovely. Brilliant.
Well done with that. Yeah. No.
Brilliant. Thanks. Bye.
Yeah, so you have a nice aim there. You've got your percentage, and you've got your timeline, and you've got your real focus. Now, drilling that right down is really good, and you've got ideas for your tests of change. So that's good.
Okay.
Thank you.
Thank you.
Okay, thank you for that. Is there anybody who'd like to go next? So next on my screen, I have Nicola. Would you be happy to present the aim you have?
So I think my project is a bit too big. I've just been discussing now with Rebecca. I was looking at pushing for a dedicated memory service in Bridgend, so it's sort of changing services really, slightly big. But obviously from doing this course, obviously there's been lots of gaps highlighted to us. So I have had discussions with my manager and with my colleagues, and they all agree. Hence why we've had actual chats with our service manager, who's also agreeing. So I think it's something that's gonna happen, and I just wanted like an active role in it. But as a project, I'm not sure how feasible it is. So I think me and Rebecca are gonna meet up. Rebecca's kindly offered to support, so I'm gonna meet up and have a discussion about how we're gonna break it down and make it a bit more achievable.
Yeah, okay.
Yeah, that's brilliant, because there will be things in those gaps that you can narrow right down to. It can give you some really quick wins, I think, and some good insight to help the overall picture of developing the service.
Yeah.
So that's where you're at. So that'll be really good. And if you link in with the other cohort members as well, that could actually be quite good for service development, even though it's a specific, small element, a small test of change, that can still help the overall bigger picture. And I think this is really where the improvement and Improvement Cymru is coming from. So we know there are lots of big things that are needing to happen, and they'll happen because there will be a whole plan and an implementation plan, and we're working with your service around that, Cwm Taf Morgannwg. But then improvement is also that journey of, let's drill down and look on the ground at some of the things that we know can happen, maybe at pace, maybe a little bit longer, but they're real-time wins.
Yeah.
And learning. And that's what the improvement journey is about, really. We underestimate, all of us, in all of our practice. Every day of the week we come into work and we have ideas about what we want to change. Or wouldn't it be better if we did this? Or wouldn't it be better if we did that? And that's really the beauty of improvement, and where Improvement Cymru's strategy is coming from. Our whole ethos is around getting, on the ground workforce people like yourselves to be able to drill down and actually think, well, we can do this idea, but actually, how do we know it's a problem? Let's do some more thinking about it, and then get everybody on board and then evidence it, because we do so much change that is never evidenced, so we can't spread it. So that's the beauty of this whole approach. So yeah, you'll get there, Nicola, don't worry.
Yeah.
Yeah, absolutely. And I live in Bridgend too, so if I can help out in some way as well, obviously please let me know. And I'm just not far from the town centre, so it's quite a small world. But yeah, as Michaela had said, they're it's with this kind of model for improvement, it just gives you a framework and a structured approach to be able to implement the changes you've always wanted to, but also with the data and the measures, it gives you that kind of evidence that there is something going wrong there, or something that could be improved, or some idea that you've had that you've now implemented. You can then evidence that, saying, look, we've actually got a 20% increase in uptake or reduction of waste or inefficiencies. And it's just being able to hand that across, say, look, here's the proof. I think there's something in this. We need to look at spread and scale on this. And it may not fit for every other clinical area, but there's definitely learnings I think we can share amongst us, between ourselves as well.
Okay.
So yeah, thank you, Nicola.
Thank you.
Okay, next on my screen is Rachel Hughes, if that's okay, please.
Yeah, so I've been chatting with Louise, and we're looking at the aim being to reduce waiting time to diagnosis. I mean, at the moment, it's very variable across Powys, and we have different professionals doing different assessments, and there's not really I don't think a very, Louise, you can explain this better probably from your experience, having been here long, but a very coordinated, collaborative approach to diagnosis. So we're looking at having more people diagnosed. So Louise and I are looking at becoming involved in that, because at the moment it's very much led by the medical consultants. So we're looking at, the aim is to reduce the waiting time to diagnosis, and looking at piloting that in Powys over a, say, 6-month period, and then reviewing how we're getting on with that. Now the challenge is going to be to get the managers on board. So Louise and I have to do a lot more thinking around this, and to meet with the managers and consultants and to plan this further. So this is where we're at. We're at the planning stage, really. I mean, we could do with some help with how to maybe overcome some of these challenges. Louise, do you want to add anything to that?
Yeah, and how to, basically that's it in a nutshell, isn't it? And we need some help, or I certainly need some help where I'm sat, to be able to factor it into my work, because I don't know how that's going to be achievable at the moment, because I've kind of got a vibe that, well, you can't just make a change like that. It has to go through many different layers, and to, many different levels of people have to okay this, basically. So I don't, it's about getting started, and how do you even go about doing it if you can't pass go, type of thing. Does that make sense? So that's our aim anyway. That's our aim, but how that's going to be achieved is another story.
Okay, yeah, I have something to add on that, but I know Rebecca's had a hand up. So Rebecca, you're on mute again, I think. Sorry.
That's a great aim, guys. I'm just wondering though whether to shrink it a little bit, and I'm wondering about the whys. Why is it that you want to be doing that? Is it about the bottlenecks within the system of people waiting for diagnosis? And if that is,
there's a long time. There's a long time from assessments to actually diagnosis, just through lack of resources, isn't it? Lack of consultants, lack of everything, basically.
So I think it's a little similar to Nicola's problem. I think we need to shrink that down, because that's a massive service. You could have lots of different elements to that. So maybe just take one of those little bits that you're trying to affect, and then you can work on little bits.
So what would you suggest for that? How, to take one element from that? Which element would you suggest?
Okay, so with the diagnosing course, with yourself, have you got the bottlenecks within the system of people just waiting to be, who've been through that assessment? Yeah. Would it be about reducing that bottleneck?
It would, but for I speak for the service that I work in Radnorshire. We've got an awful lot of waiting lists for, say, OT assessments and psychology, because there's you know what I mean, we're lacking in. We've got so many gaps.
So each of those, Louise, could be a project on its own.
Exactly.
So just pick one of those problems, and do it on that, because otherwise it's too wieldy, and then you can come back to those at a later stage.
The other thing as well is, are people actually waiting to receive a diagnosis?
Yes, that's what I'm saying, Michaela.
So there could actually be a, because the assessments have been done, but actually they're waiting to be told.
Assessments haven't. That's what I'm saying. In some cases, especially with OT and psychology, they haven't, because we just don't have enough boots on the ground to be able to actually do it. So
I think it's also around people being clear about who needs to be doing what at what stage.
Yeah.
So I don't think there's a clear pathway from referral to diagnosis. I don't think we're clear about a referral comes in, and from my understanding is there's not a designated time to, as a team, to discuss these referrals, to identify what is the need, who is best to do the assessment, and is it the person who does most of the assessment piece, is that the best person to give the diagnosis, who's had the most involvement with the client and with the family.
You're also looking at, I don't know, this is just something we found in another organisation way back, that with psychology, for example, they were waiting for psychology to undertake assessments that could be delivered by other disciplines. So, you know, there's lots to look at if you don't know what people are needing to do and what other roles and staffing could adopt some of that initiative. So, yeah, break it right down and pick one area, because, you know, it's either they've not got somebody to give them their diagnosis, it's that there's a delay in getting an OT assessment to be able to formulate the diagnosis. That's where you need to focus, or psychology to get, you know, an assessment done so you can formulate a diagnosis. There's loads of things, aren't there? You can't do it all.
Yeah,
you can't do it all.
Just pick one element.
Pick one, and then when you pick, say, if you wanted to work on psychology, you would drill down with that element and drill down again to look at where you're actually going to do your change, your idea of change.
Because it could be a number of reasons. It could be one, that people don't understand what the offer is. It could be two, actually they're only providing one type of assessment over the phone or whatever. It could be three. Those are lots of different change cycles that you could look at within that one little project.
Yeah, that's great. No, thank you for that. Thanks for your input there. And I think, as it's already been kind of articulated, is that start smaller and try and focus in maybe onto a smaller aim or a smaller project to begin with, because it's like just trying to say something like, you know, go and build a car. And obviously that is a long process in itself. And you're not saying you want to go down to install one bolt, but just try and go down to the granularity levels, just so you've got something that's realistic and achievable, and within a certain time frame that's not too truncated or it's not too long. I think that's just very important to consider. But get these things down on paper, write them out, reflect them with your colleagues or with partners, or, you know, whoever you think can contribute, and say, look, how do you feel about this aim? I'm trying to put this together for a project I'm involved with. How do you feel about this? Is this realistic? Because obviously, just in isolation, I don't think we can achieve as much as we can by sharing and reflecting with others. And I don't think that's any weakness. That is just being smart about going out and finding out and reflecting with other people, especially counterparts who will be involved in the project as well, because they may actually say, look, actually, I can't be involved with that. That may push the project on another couple of months now, because we've got this on the horizon, which we probably haven't shared with everyone as of yet. So, yeah, conversation with key stakeholders are very beneficial as well. Okay, so next on my list, Steve, would you be willing to share?
How are we doing? I've turned my camera off because I got a lag on my camera to my speech. It's driving me mad. It must be driving you guys nuts, really. So obviously a lot of the stuff that we've been talking about is around communication within the service. Now, there's a couple of reflections on that, really. Obviously, some of it is feedback from our forum that we had around sometimes the disjointedness of the service going through it, so not knowing the next part of the process. And then equally, like I said, probably the follow on from that is the amount of probably telephone calls we get from carers or patients asking for that update of where we're up to next, what's waiting for next, you know, and that can obviously take up quite a lot of time with our memory service colleagues as well. So really, obviously, our idea is really just around that kind of just to whether it's the wording of the goal, really, isn't it? You know, it's whether it's to improve communication on the assessment process for people under assessment and carers within the memory service over the next 6 months, and then try and put a figure of how many people we want to get out. Get this, I know, a service information leaflet or service journal too. Ideally, you want 100%. Everybody on first assessment should be provided with it and then updated regularly. So that's kind of where we're up to with that. We've got a little bit of a leaflet in process. And again, thinking about, you know, going back to those, that kind of the 5 whys sort of stuff and that root cause analysis of where we're coming from with this, really. You know, why do we need the service leaflet? Well, because we're getting lots of phone calls in. You know, why are we getting lots of phone calls? Because people aren't kept up to date, blah blah blah. So going back through some of those has been really useful at the moment for us. And then obviously from there, obviously it can improve a couple of ways really. I'm just thinking about those outcomes that from this that could be achieved. So it could be, you know, the amount of times clinicians have to spend on new assessments potentially. It could be the fact that could we use more of a journal kind of process? Actually, it prompts the pathway quicker, so it means that pathway is followed a little bit speedier, so the time to diagnose would be quicker. And then equally that bit at the end of being able to provide a written diagnosis a little bit faster. So if the clinician is writing into the journal at the end of the whilst delivering diagnosis, and actually that piece of written diagnosis is done much faster than just going back to the office, rewriting out a letter and resending it. So there's lots of little bits of outcomes that we can look in there really, and obviously through the PDSA saying it's right, what have we got at the moment, can we have a look at it, do we need to bring in speech and language to have a look at the content to make sure it's appropriate, obviously linking in with doing Welsh translation, all those sorts of bits and bobs that we're thinking about in terms of the PDSA cycle and work it through really, and using whatever Judith's got in the West.
Yeah, no, that's great. Yeah, thank you, Steve. Yeah, sorry, Judith, do you want to add anything into that?
Oh no, I was just going to say happy to share resources, Steve, if you do want any. And there's a really nice document by Deep about developing resources for people with dementia and about how to lay it out and everything. So that might be quite a nice one to reference as well.
Yeah, perfect. Thanks, Judith.
I'll send it to you in a sec.
Could you pop it in the chat as well, Judith?
Yeah, sure,
Maybe
sure.
we
I'll
could
do that
share
now.
it on the Padlet for everyone. That would be great. So coming back to your overarching what you want to achieve then, Steve, that's very much around people being communicated in a more timely manner and consistently.
Yep.
Yeah, so it's trying to get a baseline. If you've got a baseline on how often they're communicated, then you would get your increase, wouldn't you? And then that realistic target of, you obviously would like everybody to have 100% within 6 months.
Yeah,
that would be achievable, or something like that, you know.
That's right. And I suppose from this point of view, in terms of that journal that we haven't got in place at the moment, are actually baselines that we haven't got anything. So, you know, at the moment, anything is better than nothing.
Exactly. Yeah, we've had a couple of projects where there are no baselines because there's no standard to follow and nothing's happening in practice. And that's not a problem because you're improving communication, aren't you?
That's
and
right.
you can get all kinds of feedback. Well, you do have some evidence that actually, because you've got people ringing in regularly.
Exactly, and those are the kind of the indirect measures that we've got that are kicking about really, that we need to just probably put a bit more of a finger on them really to understand how much time that's taking up, etc., etc.
Exactly, and the number of, you know, if people are documenting that people are ringing in wanting to know what's going to happen next, then you can get almost a ballpark number, and then you could actually measure whether they stop and they reduce.
Yeah, that'd be great.
Yeah, absolutely, and with measures in mind as well, it's just clearly defined in what will be the time frame and what frequency of measure as well, and so you have a standard approach for that. So obviously, if there is a counterpart or somebody else who will be working alongside yourself or on an opposing shift, don't leave it open to interpretation. Just because I think obviously, if they think, oh, well, okay, I'm going to do it at the start and the end of the day, yeah, but what about the middle day? Or, you know, if there's different kind of schedules for the clinics, etc., or again, depending on what level of granularity you want to get down to, just try and clarify that to begin with. And like Michaela has already mentioned, I think there may be some measures or data there that maybe we haven't had time to stop and analyze or look at and go, actually, no, we are capturing that. So we can actually look at that, and that will give us a, you know, a measure to go forward with to prove we are improving the service. And I wrote a few things down as well while you're speaking as well, Steve, as well, just with regards to communication as well. So actually introduction of, say, feedback loops, or trying to create visibility across the system. Also with a leaflet process as well. You will get into the tools later on, so I don't want to kind of bamboozle anyone now, but using techniques such as process mapping. So if you just a high level overview, it is just spreading a process out, just clearly identify all the steps within the process. Then you can look at the waste or any issues within the process. But again, this will be gone into depth at a later stage, so please don't worry about that now. But that could be something very useful for yourself as well to go forward with, just to look at what sections of the process you don't even need. Or again, like you said, if there's lots of manual interventions, maybe we could have something to put onto the system so it's visible to all instantaneously, as opposed to having to try and find bits of paper or hand delivering bits and pieces back and forth, etc. So look at waste within the processes. But again, that will come through PDSAs, just trying new things and seeing how what difference it has made.
Thanks, Mark.
Okay, no problem, Steve. Okay, so Janet, I think you're next on the list. Are you happy to present your aim?
I'm working with Steve.
Steve, okay, fine.
Yes, he's explained. Thanks.
Oh, okay, sorry. Yeah, there are a number of people working together, so apologies if I double up. Is there anyone who hasn't spoken so far? I'm just looking at the list now. Or have we heard from everybody? Okay, I think, is that about right, Michaela and Rebecca? I think we've heard from everyone now, haven't we? Yeah, okay, so well, we're at 25 to now. Would anybody like to go back to their aims now, or go over any more, or discuss with the group their aims to see if we can work together to try and help formulate further ideas towards that? If you would, please raise a hand. Okay, Rebecca, you're on mute again. Is there a...
I think that's all good, Mark. But of course, people can come back to us also via email if you want to talk to us outside of this session. And we're happy to meet with people and go through that in a bit more detail. So, yes.
Yeah, absolutely. And again, if there is anything that's been covered today, sometimes when I get excited, I can speak a bit quickly. So if there is anything that's, and I'm a bit of a nerd for improvement. So if there is anything you'd like more clarity on, or you'd like some more information around, or even if it's just a quick Teams chat, just please let one of us know and we'll do our best to answer that. I'll get back to you or put some time aside. So again, we really want to support you throughout the process and make sure you're comfortable with producing the aims and going forward with the project. But as it is, this is the model for improvement. So it's going to be a staged approach as well anyway. So we will be having future sessions. I think there is one already set in, is that right? So what's the next one? Is it the 22nd, I believe? Yeah.
Yes, okay. There's one set in, and that's where I don't know if you're doing that with Lisa, Mark, but it's where the tools for how you can go about getting your project off the ground, the tools you would use improvement. They're going to do a little session with you for the day about going through the different types of tools that you could potentially use in practice. Not to overburden, but actually assist you and help you in thinking about data or measurement, as we call it, and even, you know, some ideas about, you know, how you can engage with people. We can bring a lot of things to that mix, not just about the improvement measurement element as well.
And just to let you know, I am be visiting the mass services across Wales. I've been to Powys so far. We're there. We're about to start it in Halvar in the next few weeks, and I'm then over to Cwmtaf. So I'm slowly getting across the country, and we will be looking at some of those tools, some of those process mapping, some of those fishbone and other tools that you'll get to hear about on the call as well. So you'll hear about it on the call, but you can work with those with me in practice as well. Thank you.
Yeah. Okay. Yeah, that's lovely. And yeah, just to go back to the tools as well for the next session, if that is going to be the next session, which I'll discuss with Lisa Henry. You don't have to take them all in. So again, don't try and get bamboozled and wear your mind out trying to think and take every one of those tools in. Get a high level understanding of each one. Think how it'll fit. You know, it'll be the master key to what you need to achieve. And then try and take more into that and understand more. Or then we can request some more information. Say, look, I really think process mapping will really be beneficial to myself, or data capture, or whatever it may be, or measurements, how we capture measurements, etc. If you'd like to know more about that, then that's what we'll look to do. But I'll have a conversation with Lisa Henry. I'm not sure to answer Michaela's question if I'll be part of the next session. But if I'm free, then I'll be more than happy to do so, because I kind of came in on two wheels, and but it's been a really good session. So thank you all for your contributions and being so open and willing to share. So I hope you've enjoyed it and it's been comfortable for yourself. So
thank you, Mark. I just want to say a big thank you. Stepped into the breach at the last minute because Lisa had been unwell. So really good. And I suppose let's take a little bit of a census from the group. Has it given you an understanding of improvement? I mean, this is our little improvement project now. Yeah, so it's been a helpful session. Yes, Anne-Marie?
Yeah, I think this has been really beneficial for me, you know, because it's given me a bit more structure. Obviously, I have never done a QI project like most of us here. So I think I'll be able to work on this now, and I do appreciate it. Thank you, everybody.
Yes, no, that's lovely, Anne-Marie. And I put some little links in the chat, and they'll go on the Padlet as well, on the improvement column, because we've got a column for that. We're putting on the Padlet, and that's just the IHI, which is sort of the founding area of improvement, using the model for improvement. So that can give you some background reading, and they're quite easy to use. The resources there, they're easy to follow. They're broken down quite well. There's also Improvement Cymru and what we've got on our website as well. So look through those things. And as Mark said, there's, please come back to us with anything you want to check out or check through.
Yeah.
One of the things I would urge you to do is where you've been sort of funneling and firming up your Project AIM, your initiative for change, take that back to your managers and your line managers and get buy-in there as well, because they need to be supporting you to be able to actually take this forward. And part of taking this forward, I know we've got pressures in work and trying to find different bits of space really to do the development here, but the overriding thing is if you can get that space and you can undertake that practice and you can do the improvement project, that is helping the service. So it's about a bit of a medium to long term gain if we can just put that effort in early doors, and they need to support you to do that, because that's the whole point of what this course is about. Actually being able to make those changes in practice that can help flow, can help people get diagnosis early, can help them get their interventions early. So we need you to, engage with them, have that buy-in. And then from our point of view in Improvement Cymru and what we're doing is coming around that with your organisation and your service managers to support that message as well. So it's almost like a three-pronged approach, isn't it?
Yeah, we'll stay online if you've got any questions, so you can ask those as well as we leave the call.
Yeah, and yeah, just to echo the points that have already been made as well, just if you can put as much as you can into the planning stage, just because it'll pay dividends down the line. I know, say sometimes if we can we'll see something, we want to go fix it, and rush in, and then we'll trip over something else, or maybe someone for the up or downstream may be affected by it. So just try and consider what parts of the process will be affected, and again, like to reflect with other people. But like you said, we've already said, as we already said, we'll be there to support you along the way with the processes, any techniques and methodologies that you need support with. So again, if you're not sure, please do ask. It's not like to send you off now, right? Got to go do this project. This is just the introduction to it. So yeah, thank you very much for your time.
We're going to be popping some sessions with Tony, Shanazy, myself, Rebecca, and anyone else who wants to join regularly now between now and February. We're looking to do the improvement projects sort of showcase round about February, March, and we'll put that date so that you've got something to work to there as well, so that you nearly choked then, Rebecca, did you? Well, falling off your ball. So that gives us something to work towards, doesn't it? And our learning and making sure that we're connected in together so that we can think about some of the challenges you have, but also some of the achievements you're going to be making over the next couple of months. So thank you, everybody. And anybody wants to stay on the line, as Rebecca said. Other than that, we're going to give you time back, which is always wonderful, isn't it? But no, I'd like to say a big thank you to Mark. Very much appreciated. No
problem. Like I say, you only get out what the participants put in as well, to be fair, not to be cheesy about it, but it's been a really good group. So we got a little laugh as well. But no, thank you so much for your time, guys. And yeah, look forward, hopefully see you in the next session.
Thank you.